Hello, and welcome to the webinar, Hearing and Vision-Related Practical Strategies for Clinical Research with Older Adults During COVID-19 Pandemic, developed by the Gerontological Society of America. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentation. We will be accepting questions through the questions feature accessible on the right-hand side of your screen. We will also be live tweeting this webinar using the hashtag GSAWebinar. Please join us on Twitter at @GeronSociety. My name is Dr. Heather Whitson, one of the speakers for today's program, along with Dr. Sweener, Dr. Reed, Dr. Lynn, and Dr. Stevens. I'm an associate professor and the director of the Duke Center for the Study of Aging and Human Development at the Duke University School of Medicine. Dr. Sweener is an associate professor, Wilmer Eye Institute, Johns Hopkins School of Medicine, and an associate professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. Reed is an assistant professor at the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health and an instructor of audiology in the Department of Otolaryngology, Head and Neck Surgery at the Johns Hopkins School of Medicine. Dr. Lynn is professor of otolaryngology and epidemiology and director of the Cochlear Center for Hearing and Public Health, Johns Hopkins Bloomberg School of Public Health. Dr. Stevens is Holloman Rampey Sentinel Chair in Gerontology and Director, Center for Applied Health Research at Baylor Scott & White Health, Professor, Texas A&M Health Science Center. We are pleased to be a part of this important program. So we can all know just a little bit about who's in the audience this afternoon. You should see a poll displayed on your screen. You can click your response and then click the submit button to lock it in. We'll be quiet for a moment while you read through choices and make your selection. And you should now see the polling results appearing on your screen. Great. As you can see, our webinar agenda today includes 3 informative talks and then a Q&A section. So without further delay, I'd like to hand the microphone over to Dr. Reed and Dr. Sweener, who will be presenting the first talk on importance of recognizing sensory loss and considerations for addressing it in a research setting.
Great. Thanks for having us this morning. If we can move the slide forward one. There we go. So I just want to give a quick overview of sort of hearing loss in the United States. This is data from the NHANES, and it's stacked together for several years. And the definition of hearing loss in this study is using the World Health Organization criteria, using clinically measured hearing loss. So this is pure tone averages, the same thing we would do in the clinic. And as expected, the prevalence of hearing loss increases with age, but I think a little bit surprising to some people because we don't realize how prevalent hearing loss is. Once we get over the age of 60 years, about 50% of all adults in the United States have a clinically meaningful hearing loss. Over the age of 70 years, it's 2/3 of adults. And this is actually using the better ear as the marker for hearing loss. If we use the poorer ear and we included adults with unilateral hearing loss, these numbers increase by quite a bit. Right now, if we use these numbers, we estimate about 38 million adults in the US have hearing loss. If you use unilateral, it's 48 million. Can we advance the slide? An important consideration about hearing loss is hearing aid use. And so hearing aids represent the gold standard to address hearing loss in the United States. And if we use that same nationally representative data and we take the question that adults actually own and use, I think use being a key word there, a hearing aid, of adults 50 years and older that have hearing loss, only 16.4% actually own and use a hearing aid. This is very low. You may see this number higher in some other estimates, but I do like these numbers because they are nationally representative. And a consideration in clinical research is that we already have a low prevalence of hearing aid use, but when adults come into clinical settings, especially into the hospital, for example, oftentimes they don't bring their hearing aids with them. Hearing aids are quite expensive, and they're very easily lost. We did a quality initiative actually at Massachusetts General Hospital recently, and of the adults with hearing loss who owned hearing aids, which was about 90 adults in our study of a 3-month just survey in a general medical unit, less than 50%, only 44%, actually brought their hearing aids with them to the hospital. And when asked why, there were a few cases where, it's just sort of an emergency, but oftentimes it's something that they're not willing to do. Advance the slide, please. So just getting an idea of understanding hearing loss, right now you're looking at the clinical representation for hearing. This is the audiogram. As we go across the x-axis, we're going from low pitch to high pitch. And as we go down, sounds are getting louder. And so what you're seeing right now is a representation of what hearing loss usually looks like. In the middle there, you see a speech banana. And then anything above that line, people can't hear. And what you see is that generally we're cutting the speech in half. And this often means that hearing isn't necessarily a volume only issue. It's really a clarity issue. A lot of the volume that someone with normal hearing might hear, a person with hearing loss is still hearing it in certain frequencies, but other frequencies they're not hearing as well. So if we present a sentence like you should go to the pharmacy before you get to your house, with hearing loss, it might look more like this. You would go to Arma E before you get to your oo, right? So we're cutting out consonant high frequency sounds with most hearing loss. And I think this is an important consideration when we think about ways we can address hearing loss. Go forward.
Thanks, Dr. Reed. So now we're going to move on to a primer about vision. So similar to hearing impairment, vision loss has significant public health implications. And last year in 2019, the World Health Organization released a report on vision that estimated that there are 2.2 billion people who have low vision or are blind, who are visually impaired worldwide. And that's significant because that equates to about 1/3 of the global population. So in the United States alone, approximately 14 million people would be classified as having visual impairment, of which about 3 million people have vision loss that's due to eye disease and cannot be corrected by glasses or corrected lenses. And vision loss, much like hearing, as Dr. Reed described, is particularly important for older adults because similarly, the prevalence increases with age. So the prevalence increases from approximately 1.5% among Americans 65 to 69 years to more than 26% among those 80 years and older. And so on this slide, I am showing different representations of how people with different types of eye disease, such as cataract, age-related macular degeneration, diabetic retinopathy, and glaucoma, conditions that cannot be corrected by glasses, might see the world. And I show this because it's really important to understand that vision loss really is more than just needing glasses. Next slide, please. So the three main concepts I hope you take away about vision loss from today's talk, from my portion, are that vision really is complex and can be impaired in a variety of ways. So there's different aspects of vision that sometimes you may measure in your research settings, such as acuity or contrast or fields, all of which are assessing visual functioning and all of which can be impaired. But the complexity of vision has implications for how we accommodate vision loss, which must be flexible strategies and really need to provide more than one solution. And vision loss, as I alluded to, is more than needing glasses or is more than blindness. And what I mean is that often the perception is that vision impairment equates to either one of those extremes. But for many people, particularly older adults, vision loss means something quite different. It is impaired visual input, which is being shown on these slides, that glasses won't correct. And again, that certainly has implications for many aspects of life, including research settings, which we're talking about today. And so lastly, these images are meant to intend to portray that impact of vision loss on people's everyday lives. So you can imagine that if you saw the world in one of these ways, it would affect how you interact with others, how you care for yourself, your family, how you move through your environment, and certainly also how you engage in things like research. Next slide.
So I think now we want to cover a few ways to address sensory loss in research settings, and this also applies very much to clinical settings for communication as well. And there should be a handout that accompanies this, so these are explained in a little bit more detail. So we're going to sort of briefly touch on these. And I think these break down into 3 general areas. The first one being technology methods to address sensory loss. And on the vision side, there's sort of simple technology, like just using quite literally like a handheld magnification device. But at this time, smartphones also offer many sort of technologic and electronic magnification leveraging capabilities. We also have the ability to enhance contrast, text to speech with a smartphone, where it's able to elaborate what's being said. Smartphones in general cover a lot of accessibility options, including increasing font size, again, increasing contrast. On the hearing side, likewise, we have simple tech, relatively simple tech, like a handheld amplifier. But at this time now, smartphones also have several apps built into them that act as a handheld amplifier, and they also take into account different frequency regions. So increasing sound where people with hearing loss generally need it. They also offer, they also offer speech to text programs, which is sort of the contrast to vision, and video conferencing. And I'll let Dr. Sweenor cover some of the environmental considerations.
Thank you. Yeah, so there are environmental modifications that can be made to make any context more accessible for any of us, whether it's vision loss or hearing loss or any older adult. And those include things like maximizing light with the use of task lighting and ensuring that there's limited or minimal glare on the task at hand, reducing excess background noise whenever possible, and using strategies such as whiteboard or pre-prepared placard cards to enhance communication. And again, I just want to stress this can be utilized for all participants, not just those that have visible or obvious sensory loss. Next slide.
And so I think the last area is for communication considerations. And in general, these are the way we actually communicate. And so many of these work for both vision and hearing loss, but ensuring attention, for example, is important to make sure that someone's ready to engage in the conversation. For vision loss, introducing yourself is important, describing images, not relying on gesture or facial expressions, whereas there's sort of a contrast on the hearing side where facial visualization is quite important. An example of this in the COVID era is by masking our mouths, we're often making it harder for adults with hearing loss to understand you. There are clear mask capabilities which can address this. We can also use video conferencing, though, to speak in separate rooms to allow us to show our mouths. Slowing your speech and not shouting are important for hearing loss. Oftentimes people default to a shout, thinking that that's going to help, but keep in mind, if we think back to what hearing loss is, increasing volume alone is not going to help. It often actually distorts sound. And I think a key for both sides is asking for feedback, as well as rephrasing rather than repeating. When someone doesn't understand what you said, and in research and medical environments, we often use jargon and we use language that's hard for people to understand. Rephrasing rather than repeating the same thing is key to helping push across points when there's misunderstandings. Next slide. And as Dr. Sweenor kind of alluded to, I think there's some last considerations here that these communication tips help everyone. And so even when someone doesn't identify necessarily as having vision or hearing loss, there's two sort of examples here. There may be people who quite possibly have, quote unquote, normal sensory capabilities. They'll benefit from these communication tips. But there's also a large group of people out there who may not necessarily identify as having hearing loss or vision loss. They may have more mild impairments. But in a stressful situation like the clinic or like a noisy hospital or a situation where unfamiliar language is being used in a research setting or clinical setting, it's good to sort of address these up front and sort of hit them head on. And lastly, I think we'll talk more about this later in the discussion, but dual sensory impairment poses sort of a conundrum, as you saw. Sometimes we're addressing something with vision, sometimes we're addressing something with hearing. For example, text to speech and speech to text, which quite frankly are the sort of the opposite of each other. But that doesn't mean that they couldn't be used together. There's sort of a benefit from redundancy. We oftentimes sort of address one sensory component as sort of substituting for the other loss. But in this case, in dual sensory, we have loss on both sides, and redundancy sort of helps.
And I just want to close with saying that the impact of vision and hearing loss on daily life really has been magnified by COVID-19. And as we move to virtual and online formats for social connection, healthcare, accessing goods, employment, people with vision and hearing impairments have certainly been left behind when accessibility is not considered. And so as we move into this new normal, even in our research settings, we have to consider accessibility. And as Dr. Reed and I outlined some strategies to make research in the time of COVID more accessible, we certainly hope that you take these into consideration even beyond the pandemic.
Thank you. That was an extremely helpful, informative talk. We are going to move next into Dr. Lin's talk, where he is going to give us some of the adaptation that has occurred in the ACHIEVE trial in light of the COVID-19 pandemic. And I just want to remind people that we are going to complete all of our talks and then begin our question and answer session toward the end, but please be thinking of your questions for any of the panelists. Dr. Lin?
Thanks, Dr. Whitson. So what I'd like to do now is following up on the sort of the strategies and the tips that Dr. Reed and Dr. Sweeter went over, is to give some more of a pragmatic case study, for instance, of how we've been able to adapt an ongoing study of older adults to deal with essentially the challenge with COVID and sensory impairment. So the ACHIEVE trial, as Dr. Whitson just mentioned, this is an ongoing trial where the fundamental scientific question is basically among essentially older adults, 70 to 84-year-old, these are community dwelling older adults with a mild to moderate hearing loss. And again, as Dr. Reed mentioned before, roughly about 50% of adults in the population would actually have a hearing loss in this age range among that age group. So this is the majority almost of older adults. But the question is, among these group with hearing loss, does provision of a hearing loss intervention compared to a successful aging education control intervention? So basically, everybody gets something, but one group gets their hearing loss addressed, other group basically gets sessions around nutrition and diet and exercise. Does that in fact reduce rates of cognitive decline over 3 years of follow-up? So that's a primary scientific question. The main inclusion criteria, as you can imagine, this will be relevant just to setting up the study and how we're able to adapt. Again, these are people with mild to moderate hearing loss and who are not using hearing aids. Importantly, at baseline, one of the inclusion criteria was they had to have vision as measured with, it's a near vision card. So basically you read it about 16 inches away and you have to read the smallest line of text. We had to basically only take people who could read text at 14 point font, essentially, or smaller. The rationale for that, specifically excluding people with more severe visual impairments, was since the primary outcome of this phase 3 trial was cognitive functioning, of which some of the cognitive battery includes visual measures where people had to read text. We had to exclude it in the beginning as a potential confound. It's not ideal from a generalizability standpoint, but for the purpose of a phase 3 trial, we had to exclude that. So that excluded, again, anybody with who was not able to read essentially 14-point font. And again, these are community dwelling older adults. Next slide. So Prior to COVID, again, where we already were with the study is that we had done all the baseline visits and randomization occurred between 2018 until October 2019. Then once someone is enrolled in the study, they all got these 4 study intervention visits, either to get hearing aids and all the counseling around how to use hearing aids, or they got one-on-one sessions with a health educator. Fortunately for us, just in terms of timing for the study, all of those intervention visits, which are quite lengthy, they're about an hour apiece, they're all done in person, all of those had been completed already before we were faced with COVID. So those all finished up by February 2020. And then since basically then, we've been doing for everybody, there's roughly about 1,000 older adults, they've been having semi-annual visits. So every 6 months, they would come into one of these field site clinics. This is a non-healthcare clinical setting. These are all in standalone research facilities, where typically be about a 3-hour battery of examinations. So the first hour is all around neurocognitive battery, looking at memory, executive function, attention, things like that. And then there are a host of secondary outcomes as well, focused on things like dementia diagnosis, depression, physical function, et cetera. Next slide. So just a brief summary then of prior to COVID, what was happening in this sort of phase 3 trial is that these are all conducted in person. These are all in person at field sites. We would send a car to someone's house, pick them up if they couldn't make it in themselves or if they didn't have a driver. All the staff at these sites, these are standalone research facilities, were trained to work with older adults using a lot of strategies that Drs. Reed and Sweeter went over before in terms of slow speech, face-to-face communication. Participants were always instructed to bring any sensory aids they use at home. So obviously people got randomized to hearing aids or asked for hearing aids, but if they obviously use reading glasses, anything they normally use at home, they would come in with. Importantly, for the purpose of this study, where neurocognitive functioning is the main outcome, we had to make sure that neurocognitive testing in and of itself is not confounded by having hearing loss. And again, majority of people in older adults have hearing loss, but the confound we had to avoid though was that someone, for example, wasn't able to understand the instructions, or if they were asked to memorize a list of words, that they didn't misinterpret or mishear a word, and hence were not able to repeat it back later and got marked wrong, right? So that would be a clear bias or a confound with that. So the way we ensured against that is for all individuals getting neurocognitive testing, prior to the neurocognitive test, the psychometrician who's doing the neurocognitive testing is they would do something called an ensuring speech understanding test, which we'd pilot and develop. Basically what they did is quite simple. They would read 5 sentences face to face as they would give a neurocognitive test, and the person would be asked to repeat back each sentence. And then they're scored as how many words they repeated back correctly. So usually there are 3 target words for each sentence, hence 15 words over 5 sentences. And then for people who scored 14 or better, we just continued as proceeded, and we took that as understanding as an indication that they would understand well. For anyone who scored less than 14, then we took accommodations by using a slightly louder tone of voice, giving written instructions, etc. Importantly, I think what we all need to understand though is for someone with a mild to moderate hearing loss, face-to-face communication is usually not an issue. Very few were not able to get 14 or better, but having that in place to ensure that it wasn't biased was very, very key though. Importantly, one thing that Dr. Reed went over before was the potential of using portable amplifiers. We never use those at all, mainly because we want the psychometric testing conditions to be transferable to real world situations. Namely, if they weren't using amplifier at home all the time, we wouldn't want them to use it during neurocognitive testing because that could actually affect how well you perform. The main thing is you want to get around the confound that their hearing loss is not preventing them from understanding words correctly, and that's something you actually test objectively. Next slide. So when COVID began hitting, essentially mid-March, all sites to this day still have all shut down all in-person clinical visits. So when we began to adapt, there are certain planning priorities. The first one always, as you can imagine, was participant safety. For a trial like this, where we're not talking about a risky intervention or interventions critical for someone's health, fortunately, that was not too much of an issue. The main thing was ensuring that participants understood what was going on with the study and when not to come in, for instance. And the second priorities are always around research integrity, namely how to maintain engagement with participants, how to still deliver the booster interventions, even though the main interventions were done up front. People got booster interventions every 6 months, and how to prioritize data collection. Next slide. So very early on, we convened something called a care committee across all the field sites, and then we sent a postcard mailer, pretty large 16-point font on white text to increase contrast, that basically informed participants that the trial is temporarily paused for in-person, but that we would maintain phone contacts. So this went out very, very quickly. And then there's also, for all the staff who were potentially getting phone calls, we provide a COVID-19 guidance document for what to say, what not to say, things about COVID, if these older adults, and again, many of these older adults are vulnerable by virtue of being community dwelling and older adults sometimes, about what to communicate, how to connect them with the resources. Next slide. Then the big thing we had to do within a few weeks then was to standardize procedures. So the top three is basically, we had to develop a memo to basically how to convert all the procedures to phone-based visits. Not everything obviously converted to a phone-based visit, but we had very strict protocols for how people contact people, the language they used, how to adapt the booster interventions for the hearing and aging education treatments. And then for a cognitive test, we couldn't do the whole neurocognitive battery. We just did something called a 6-item screener. We had to standardize that too. So it was only being done via either a landline or cell phone call, but not over a Skype or FaceTime. Since that affects the quality of the sound, we didn't want there to be variation between people about how the quality of sound they're getting when they're getting a cognitive screener even. A big thing in the bottom left there is that we always sent out in advance and made available on the website. People would access the website, if not, they're mailed it, response cue cards. So they could follow along with instructions for the phone-based surveys or the neurocognitive testing. There's always cue cards they could follow along with to aid with the auditory-only communication on the phone as well. Next slide. The medium-term actions then, basically still in present day, is adapting then all the quality control procedures, how we actually track missed visits, missing data to ensure it's still consistent across sites, between sites, and between examiners even. Right now, we're in the phase now of beginning a full phone-based neurocognitive protocol, which again has to be adapted from the previous protocol. And then we're also planning for enhanced retention efforts in the long term as well through additional context participants. Next slide. The last slide here is it's just sort of the future now. I think for many of us, we realize that there will be no resumption to full normality with essentially what's going on COVID probably for at least 2 years. And during this time period, even if there is some resumption normality, older adults still may not want to come in for visits because of the risks they're possibly placed in. So one thing we're beginning to consider now is using something called GrandPad. It's a terrible name, but it's a company that's developed a very user-friendly tablet that's sent to someone's house. It comes internet already programmed. It can just have one button that allows you to video conference very quickly. And we're thinking about adapting that now to allow for more robust neurocognitive testing, as well as other testing, since you'll be able to see the examiner, and then the participant will not be limited by technical limitations about how to use and how to get on a video conferencing platform. And that is my last slide. Thank you.
Thank you so much for that, Dr. Lin. And now we're going to hear from Dr. Stevens, who's going to tell us about adaptations made in another clinical study, the Dementia Care Study. So take it away, Dr. Stevens.
Thank you. So yes, I'm representing the Dementia Care Study, or the DCARE study, which is led by Dr. David Rubin, who's the principal investigator at UCLA. And I'm the PI of one of 4 clinical sites across the country that are recruiting dyads of individuals living with dementia and their family caregiver. Next slide. And the goal of the study is to do it's a pragmatic clinical trial to compare the effectiveness and cost effectiveness of 3 different approaches to dementia care, which have all proven to be effective previously. One is an evidence-based intervention that was telephone-based and very commonly delivered by community-based organizations like Area Agencies on Aging. It's called BRI Care Consultation, created by Dr. David Bass. An evidence-based approach providing dementia care within a healthcare system. It's an approach that was designed by Dr. Rubin at UCLA. And the third group is the telephone-based support program provided by the Alzheimer's Association. And because of the randomization has 11 to 1, so over 90% of the individuals end up in the first 2 arms. As I said, it's being conducted at 4 clinical sites across the country, representing various geographical regions. They're both organizations such as my own as a healthcare organization, as well as traditional academic medical centers. With the program had been operational in the enrollment phase for about 8 months when the advent of COVID. And prior to the advent of COVID, we did an in-person baseline interview in which the persons with dementia and their family caregivers would come into our settings, either a clinic setting or a research setting, for an interview. At the onset of COVID, we immediately started to revamp the study to have all interactions be conducted by telephone or telehealth. Next slide. So our objective here was to first convert to be able to find a way to go from in-person written consent to a telephone-based or oral consent, verbal consent. The second was to convert the baseline data interview, which required a cognitive assessment of the person with dementia, and then also some standard caregiving interviews with the person, with the person's caregiver. And then lastly, one arm of the study, the clinic-based or healthcare-based arm of the study, required a clinic visit, so that had to be converted to telehealth delivery. So just to focus on a high level here, what our primary task was really to go back to the IRB, both the central IRB and the local IRBs, and say, hey guys, we need to keep this study moving. We've got to retool. We're going to go from in-person to telephone-based. How can we get this done? Then we had to go out and do some very fast pilot testing of our telephonic approaches and other approaches of doing e-consenting to figure out how many families we could actually approach or would have the availability to do a web-based connection to us, and how many would be strictly a phone-based connection. And then we had to modify some of our data collection techniques, and including some significant changes to the data flow structure and REDCap. So some significant ways we had to move forward by adjusting our protocol. Today, I really want to focus only on the changes that were related to the modifications that were needed for the cognitive assessment of the person living with dementia. And we were using the MoCA, the Montreal Cognitive Assessment. And we had enough knowledge ahead of going into our changes that were COVID related to know that most all of the individuals enrolling in the study had moderate to severe cognitive impairment. So as we move forward to do telephone administration, we also looked at the shortened version of something called the DONG version of the MoCA, and we're able to pivot now to the regular full MoCA to a shortened telephone version of the MoCA. Challenges related to that is with our approach, we needed to know some basic contextual information about the interviewee, because we begin it by trying to figure out the basic level of functioning of the person with dementia. So for example, if a person is non-responsive and totally unaware of their surroundings, we would not go forward with the interview because it would be just burdensome and potentially agitating to the person. So we begin with a couple of questions like, can you tell me where you are and who's sitting next to you? And we had done this already in our in-person interviews to just start to get to know people and figure out kind of where they might be in their level of cognitive impairment. So we didn't have that. We no longer have that available to us when we're doing it by telephone. So we had to kind of know a little bit about what the setting was going to be like, some pre-planning to know where the caregiver was going to be, what location would they be in, so we would know the answers to those questions. We also realized that we needed to have as much information as we could about the person's cognitive and sensory impairment prior to the call, so we could start to make adjustments and have expectations to know a little bit more about what was going to be the overall context of the cognitive assessment. Agitation and dealing with the potential of agitation is always important when working with people with dementia. In an in-person interview, you pretty much can know from the very beginning, as soon as someone walks into the room, you can kind of start to judge their level of engagement, what particularly might be agitating to them, and you can work around that. On the phone, you're kind of going in blind, of not knowing what their verbal cues might be, that what the interview might be bringing out in them is a higher level of agitation, which is, of course, unfortunate for everyone involved, the person as well as the family caregiver. Some very specific things here to administration ties in earlier to what I think Dr. Reed had spoken to, is that the expression of the letters that are part of the cognitive assessment when you're asking people to either asking a letter and then verbal fluency, you have to be very careful in pronunciating it, that the interviewers pronunciate it clearly, and that you ensure that the person has actually heard the correct letter. We also had to ensure that during the short version of the MOCA over the telephone, that there was a sufficient 5-minute delay in the recall delay. So as you know, in the MOCA, you do a list of words and then a trial for immediate recall and then a delayed recall. The way the shortened version is arranged, you have to make sure that there's a 5-minute delay in that. That means we also had to have some filler to go from talking about the asking the questions on the MOCA to maybe then having a time where you're talking about the weather or talking about some other events to keep the standardization of the measure. Next slide. Some of the things that we have learned in practical strategies, many of these have been mentioned already, and some of them are specific to the MOCA and some more general to the overall assessment. Providing copies of materials and branding the paper that we provide materials on helped a lot with getting the message to the caregiver of basically asking the caregiver, can you assist us in creating an environment in which we can do the best possible case of a cognitive assessment on the telephone with a person that we know to have a cognitive problem. It's actually in the attention section of the MOCA, there is tapping required in the presentation of a long string of letters. And we had to figure out what's the best message, what's the best way to hear the response. In the clinic, we would just do tapping on the table, which is fairly common. What we had to figure out is it better to tap on the phone, or was it better for them to clap? And so we figured out we have to test that before we even begin the assessment to ensure that we have the best method for this person on this call. So learned how to kind of get around some of the problems that we know are going to be inherent by doing some pre-work. Some other things, just in amplifying the importance of having good interviewing skills, using the participant's name quite frequently, stopping in and asking how they're doing, or are they willing to continue. That's especially important if you go beyond the short MOCA into the long, full version of the MOCA that can be pretty tedious on the individual. And lastly, it does require you to pay more attention to the caregiver's behavior, because we all have seen that where caregivers will often try to assist a little bit and help a little bit, and you have to monitor for that while you're doing the phone interview as well. So it's pretty burdensome on both sides for the interviewer and the interviewee, but we're finding a way to make it work. Last slide. Just a few comments from family caregivers who assisted in the pilot testing. And these go across the entire interview, not just the MOCA. And you can see here, I won't take the time to read all of them. But one of them that I want to bring out is what we heard earlier is use of visuals. So we provide hard copies of all of the materials that are going to be needed for the caregiver interview ahead of time. We've learned that to be very valuable, often color-coded different interview tools so you can be very clear in directing people to the proper interview. We have also learned that for some individuals, the use of video conferencing, in our case, we use Teams, to be able to have screen sharing and being able to direct individuals specifically to what you want them to be attending to is very valuable with a tool like Teams. Then one last thing was mentioned earlier, the overall environment is extremely important. And we work with the caregivers now to have them think about that ahead of time so that when we begin the interview, that they have reduced as much distracting noises as possible. And I'll stop there. Thank you.
Thank you, Dr. Stevens. And I want to thank again all of our speakers today who I think have done a fabulous job of giving us some actionable tips to use as well as some concrete real-world examples. There is no blueprint for how to conduct research in the time of COVID, so we're all sort of learning this together here, and I appreciate you sharing your experience. I did want to highlight what several of the speakers noted, which is that the COVID-19 pandemic and the need for social distancing has really magnified the challenges experienced by hearing or other vision or other sensory impaired participants. But those challenges existed before COVID, and they'll continue to exist after COVID. So I think it's important that we always be mindful of how to accommodate these challenges in our participants. So to that end, I wanted to point out a couple of things that were happening on this front at GSA even before COVID. So back in March, a special collection was released for World Hearing Day, and you can see the links there. This was particularly on accommodating hearing impairments and research and the impact of hearing in older adults. And then there's a sensory health interest group, which had its inaugural year this past year that Bonnie Lynn Sweener and I are the co-chairs of, and I would be quick to say Dr. Sweener is the engine behind. So we hope that this call will pique your interest enough to join the interest group and continue the conversation. Now we are going to get ready to move into the Q&A session. So let me just give a couple of sort of announcements. So please know that there will be a webinar survey that will automatically launch after the webinar. And in an effort for continual improvement, we would really like to hear your thoughts. So please provide your feedback by clicking the survey link at the end of the webinar. Also, approximately 3 days from now, all the registered attendees will receive a handout of the slides and a link to the recording of this webinar. And you will be able to download a copy of the presentation slides, and also from that, a list of the strategies for working with participants who have sensory impairment from the website, which will appear in that announcement. So now, moving along to our question and answer session. So you will be able to type and send your questions using the questions feature that you should see in your dashboard on the right side of your screen. We won't be using the raised hand feature today, so if you have a question, please just ask the question to the panel. And my colleagues and I will all do the best to address as many questions as we can in the next 15 minutes. And let me see if I see any questions yet. Looks like some are showing up. I have a question for Dr. Lin. Does the GrandPad work for participants who do not have internet access at home? If not, how do you work around this?
So thanks for the question. So the GrandPad, it does actually. So it comes pre-configured with already the, I mean, they have to be in a cellular zone where there's a cellular signal, like a phone, for instance. But it does come already really activated. You just hit a button and essentially you're ready to go. The nice thing about the company is they originally designed to, it was more of a lifestyle thing for people seniors who couldn't connect with their relatives or their kids, for instance. But since then, they've rapidly been transitioning more and more to more of a telehealth type of device as well as for research. So they are able to actually work with you to configure the device however you like. So for the ones we're using for research in the future, it's only going to have one button on it, and that purely allows them to teleconference with us, and it takes away the extraneous features that would probably interfere or maybe even confuse some folks.
Great, thanks. I see another question. I think this is asking, are there any suggestions for standard practices for accommodation and adaptation for remote testing measures? So when we don't have the opportunity for lighting in the room and that sort of thing, but particularly collecting, I'm assuming, assessments either by telephone or Zoom or video conferencing.
I think I'll chime in real fast, and Dr. Sweener might have some really good tips here too, but I think in general, video conferencing, whenever possible, is vastly superior to telephone. And when using video conferencing, using real-time speech to text, and specifically making sure the text has good contrast and is large enough. And also, when you're using speech to text, I think it's important to consider how rapid you speak. We often speak sort of rapidly when we're not face-to-face with somebody, and I think we sort of forget that human component, but slowing down becomes even more important when you're using something that may experience some lag.
Yeah, thank you. I agree completely. You know, the mantra of accommodation strategies is to be flexible, and I recognize there's a tension in research settings where you also need to have a standardized approach. And so I think, you know, for individuals that have sensory loss, all the things that Dr. Reed just indicated are critical. You know, you do need to understand that not all of your participants are going to come to the table equally in their hearing and vision function. And so I think the primary thing to think about is to make sure you're asking the participant how they're doing, if they're having any trouble hearing or seeing, and doing that always, especially now. I will also add that if you are going to prop up or use these virtual formats like Zoom, also understand that you may need to help participants even access those platforms, particularly for some individuals with vision loss. Just even opening and accessing and gesturing to open them could be a challenge if they're not, if they don't already have accommodations in place. So I think I'm giving kind of a long answer, but the idea is to be flexible, to get them to where they need to be, and then be rigorous during the testing once you have the accommodations or the adaptations set in place.
I'll also make the comment that I think that what we found is in adapting some of our in-person protocols to be socially distanced, we've actually found that we can be even more standardized in some ways when we had to come up with a new format. And the reason is we now have videos that we play for the cues. This was to get around the idea we were still doing in-person study visits, but with the masks, it was too limiting particularly for our hearing impaired participants. And so what we've gone to instead is at the cognitive assessment junctures where we might before have had different research assistants reading out, say, lists of words for recall. Now we just play a video where every participant sees the same person in the video without a mask, reading the same list of words in the same way because it's a standardized video. So in some ways, we actually feel like this, trying to come up with a workaround that didn't require us to have a mask actually required us to do better in terms of the standardization. And I would say the everything that Bonnie said in terms of accommodating whether it's truly a vision impairment or just people who may not be as technologically comfortable, being prepared to start the video for some participants who may not be comfortable with that. There's another question about, we are interested in the clear masks and do they meet criteria for PPE? The answer is there are clear masks that meet the criteria for PPE. They're a little hard to come by. We've had some on back order for a while now. I don't know if my colleagues at other places have had an easier time getting their hands on them.
I can comment to that. The specific company Clear Mask, which has sort of become one of those generic terms now, but the original Clear Mask, they do meet standards for PPE, and then there's one other one out there that does, that I'm blanking on the name, but both of them are back ordered, and Clear Mask, which has started to catch up at this time, is currently only filling bulk orders. So I don't know if they can provide something that is relatively small. If a hospital system was buying like 10,000, though, they are taking those orders.
Great, thanks. So I'm going to move on to some of the other questions so that we can have time to answer some others. So there's a question, can you estimate how much time it took to retrain the research assistants for these new protocols?
So this is Frank, and I can take that. So, you know, in terms of training, you know, prior to COVID, for in-person testing for psychometry or physical function, anything like that, you know, that we had very strict quality assurance procedures in place about number of supervised sessions before someone could do it and things like that, and also periodic recordings. Adapting to those staff who had already been doing already in-person visits to phone was not hard at all, actually. In fact, I mean, I think it was just more or less going over some of the procedures and best practice about, you know, speaking the phone and things like that. But we didn't have to retool beyond that. One key thing, though, was a question for us, which we're still dealing with, though, is how do we maintain ongoing quality control, though? So in the past, we had people record themselves or in the in-person sessions, and they'd be periodically reviewed. For the phone-based ones, we have not been able to do that because just there's some logistical issues with having to record on the phone, which got a little complicated. So we have not been able to maintain the same level of QC as we did before. But I think from the initial, say, quality assurance point of view about training people up to do it, it was not difficult. It was just more going some best practices. The bigger thing was probably even just how the data was recorded. That took a little bit of training because previously it was in a computerized database system. It was still doing that, but now there's some different features per se, you know, notate and things like that. That was where most of the training was involved. And that's a webinar we did maybe once or twice, go over more the finer logistical points.
This is Alan from the DCARE study perspective. I would say probably about 2 weeks of the teams working together at the individual sites, doing practices, you know, getting feedback, doing pilots. And since the staff was already on board, it was a bit easier that they could work together to identify where they needed to improve their skills. And then also we had to completely change our data entry system. So that was added some significant time as well. So for us, I would say it was a you know, a pretty significant investment of time, but was required, and you know, is continuing to function in that way now. So.
Great. And then the maximum length for the phone interviews, are you all concerned about respondent burden? I think is probably embedded in that question.
Yeah, we do frequent check-ins, and we also did some pilots. And when we first started, we kept track of the times of the interviews to see if how they compare to the in-person interviews. And in general, the entire consenting and baseline process for us on the DCARE project is running anywhere from about 60 to 90 minutes. It's pretty standard. And then that is being done in one session. We offer people to break it up in multiple sessions, but for the most part, everyone does it in a single session.
Great. There's a question specifically about the MOCA, which is maybe for you too, Dr. Stevens. So how do you deal with the graphomotor component of the MOCA when it's administered remotely?
The what component?
So this would be like the when people have to draw, like the clock drawing or the trails making.
Yeah. The Dong version does not include those components. That's why it's appropriate for the telephone. Yeah. So you have to find a version. There are a couple out there that are available that don't require those, that don't include those components.
Okay.
Naming of the animals, that kind of thing, have been removed.
Right. Okay. So there's also a question about the virtual consent process. If somebody can describe a bit more about what that consent process was like, and also any tips for documenting it.
I'll go again quickly if you'd like. We do consenting two different ways. So there are 4 sites in the study. 2 of the sites, the local IRBs agreed to go to verbal consent. So the consent form was changed to be appropriate for verbal consent, with it mailed to the participant and then verbally reviewed and verbal consent documented. 2 of the other sites, including mine, would not allow a verbal consent. So we do either paper consenting by mailing the consent to the family, consent forms for both the person with dementia and the caregiver, and reviewing them carefully over the telephone, and then asking that they mail them back to us or take a picture, send the picture back, scan it, any number of means of getting it back. The most effective way is to do e-consenting in REDCap. That's the most efficient way of being able to send a link, have them review it, us review it with them over the phone, and then them do a digital signature. So for that, REDCap is by far what we have found across 3 different studies now. REDCap provided the best e-consenting mechanism.
I've had a similar experience. I'm a big fan of the e-consenting by that modality too. Mm-hmm. There's another question about encountering any third-party payment for sensory aids for older adults, and noting that this is a big barrier for many older adults with hearing and vision challenges. How do you overcome financial barriers to getting aids? I don't know, in your research studies, you may not be able to do that, but in clinical work, want to comment at all? Maybe Bonnie and Frank, I know you both are knowledgeable in this area.
Yeah, actually, Dr. Woodson, maybe Dr. Reed, do you want to take that? Actually, I think you have some probably good insights there on how to address it.
Sorry, Dr. Woodson, can you repeat the question? My headphones were starting to break up there.
Sure. So the question is about third-party payment for sensory aids for older adults, noting that this is a really big barrier for many people with hearing and vision challenges. So tips for overcoming the financial barriers to getting access to vision and hearing aids. Oh,
yeah, this is a big deal. It is, in general, these are not covered. This is something that the hospital would cover. We've done a lot of quality initiatives that I've presented on in the past about addressing hearing, and now with Dr. Sweener's help, we're starting to think about addressing vision. And a lot of times this boils down to a very cut and dry approach with the hospital of sort of showing the research and buying in bulk for the sensory aids. And when you really break it down, you can buy some of these amplification products for about $40 a piece when you buy it in large quantities, which is less than about half the cost of a bag of IV fluid. And if we consider things like satisfaction with care and how it contributes and factors into reimbursement rates under Medicare, for example, you can actually paint this as something that could actually be profitable to the hospital by addressing or to the in this case, we're thinking clinical care. On the research side, I think this is something that at this time, unfortunately, research entities will just have to eat the cost of providing sensory aids for the the benefit of rigorous research.
I would also,
yeah, Bonnie, please answer quickly, and then we'll have to end our session. Yep.
Okay.
Go ahead.
All right. I just want to say, I want to encourage people to to reach out to the manufacturers and the people who are creating those accessibility options, to partner with them in their research endeavors. That might be a path forward.
Great suggestion. And that does take us to the end of our hour. So what a wonderful webinar. Thank you again to all of our panelists and to the attendees for great questions. I learned a lot. Thank you for your participation, and this is the end of our program. Goodbye.